as a clinical embryologist and andrologist. Mm, The simple way I used to tell people is when people ask me that question, they ask me, "What do you do?" I just tell them I make babies. So when they hear that, I said, "What do you mean you make babies?" So I tell them that, okay, actually a scientist, and we help couples who are struggling with infertility to conceive um, safely, scientifically, and medically at our IVF clinic. So I just try to piggyback and tell them, do you know about the first test tube baby? That the first test tube baby was conceived as far back in 1978. So the field of in vitro fertilization, where I work as a clinical embryologist and andrologist, has been in existence even way beyond 47 years ago now, almost half a century. So before they even got to that first breakthrough, they've been doing that science as far back as several decades behind. So that's the long and short of what I do as a
Yeah.
clinical embryologist and andrologist. And to make it simpler, I work with human sperm and eggs in the lab, basically.
Okay. All right. That's that. I didn't know. That's why I'm going to ask you this. I also know that you're working in lab at Florida Atlantic University.
Yeah.
So at Florida Atlantic University, what are the kinds of work you do around assisted reproductive technology and also teaching? How does this connect with what you just said?
So at Florida Atlantic University, FAU, I mean, that's where I graduated from. I got a master's, I got a PhD, and I got a bioengineering graduate certificate at FAU. A master's in biology, PhD, also in integrated biology, but with research concentration in reproductive medicine. So what I do currently at FAU is that I'm a adjunct instructor, more like a professor. That's the title they give every one of us. I teach microbiology for health sciences or health services. That's more like clinical microbiology. Um, that's the science that deals in microorganisms, by the way. And I also teach, or I helped to start two continuing education courses or programs. One in assisted reproductive technology itself, which is the science of what we do in clinical embryology and andrology. And I also have to start another continuing education program in DNA forensics. And that's because I've worked in both fields before. I practiced in a DNA forensics lab here in Florida as well, briefly, as a DNA technician. I think that was the title they give me. So we work on DNA samples, basically to identify um, humans or perpetrators at a crime scene investigation, basically. So using DNA to identify or connect people to their samples that potentially were deposited at a crime scene. It might not be a crime scene, it might just be that you're trying to figure out the paternity status, right? Who owns the child, right? If there's an incidence of paternity fraud. Although we didn't do that so much at the DNA forensics lab, they were more tailored towards law enforcement and things like that. But then I got another position in Nigeria, Africa, with a friend of mine who actually started a paternity testing lab, right, where they actually help to do genetic testing that actually attributes paternity of a child. Right, so there's a menace of paternity fraud out there, and
Hmm.
most people are beginning to come to the realization that sometimes the child you think you have might not really be your child. It might be as a result of infide- in, infi- inf- what's it called?
Infidelity.
Infidelity,
Infidelity. Yeah.
or it could be a genuine error. Sometimes mistakes do occur. I mean, back in the days, they tell us that children can get mixed up in the world.
Hmm.
That
Yeah.
they normally would tag the children as soon as they are born before they take them to the, you know, NICU with names of parents and things like that. and they could switch babies, and every baby almost looks alike at birth. You really don't know which
Yeah.
one is which. So
Yes.
sometimes it could be a genuine error that some people, mistakes that some people make. Even in a field of IVF, I mean, we read in the papers recently lawsuits and here and there, that some people mixed up the sperm, injected egg with someone else's sperm, or picked the wrong embryos to transfer. There could be genuine mistakes like that, that could warrant paternity testing. I mean, which is now a popular field of diagnostics right now as well. So as far
Wow.
as what I do at FAU, which is the university is concerned, I teach. Right, I teach the basics of what I do, basically. So I teach microbiology, then I help to manage those continuing education courses. Then I recently got a grant to start a lab, a teaching and research lab actually in clinical microbiology and assisted reproductive technology. So we're just getting some equipment where we can run some researches, have students trained, come do DIS projects with us and things like that. So basically, that's what I do. So I'm part time at the university as a professor, and I'm full time at the clinic as a clinical embryologist and andrologist. Yeah.
Yeah. Thank you so much. I forgot that you like talking.
Well,
So
that's what.
at this point, you mentioned something. You mentioned something. Paternity, paternity fraud.
Mhm.
So, based on the work that you do you know how frequently does that happen? And is it something that's common and that?
Well, I was just trying to go over some statistics before the start of the interview right now. I was trying to see how prevalent it is, even globally, or I mean, with respect to the country where I work at as a chief scientific officer for that paternity testing lab. Um, they say the statistics is it could be as high as 30%. All right, that is maybe 3 in 10.
Yeah, that's not
Yeah,
good.
or I mean, there's a range. They say about zero point 0.8 to about 30% prevalence, and it could vary. I mean, according to demographics, location, country, even continent. But then, I mean, come to think of it, there is a lot of mistrust, infidelity going around. I mean, it's not usually with ladies per se. It could even be men,
Right.
perpetrating the act and things like that. At the end of the day, um, there's going to be a mix-up, right? So it's whoever sperm fertilizes the egg first wants the
Wow.
baby, So it's quite prevalent, and the shocker most people have like this. I mean, traveling abroad wave that recently started especially in Africa. I mean, our home country, Nigeria. I mean, the moment people get to know is when they are going to the embassy to do DNA testing. So, before you travel out of the country, they'll tell you to go do a DNA test to confirm that your dependents are actually yours. So that is when most people get to know that how come they're saying my child is not mine from this DNA or paternity testing, then a box, a Pandora's box now gets opened and now start a
Yeah.
lot of,
Wow. Wow.
investigation and things go down the drain from there. So yeah, it could be quite prevalent more frequently than we think. So
Mhm.
it all
Wow.
just boils down to trust in marriage and family. Yeah.
Yeah. And the thing about trust is that trust is not demanded; it's earned over time. You have to earn
Correct.
trust. So you
Correct.
said something now that made me think about my study, prostate cancer. We said in prostate cancer, 1 in 8 men had the chance of having prostate cancer. And we're saying that this
Okay.
is even more, it seems it's more prevalent than the occurrence of prostate cancer in men. That's that's something that is very scary. Wow.
Yeah. Yeah. Very
Well,
scary.
thank you. Thank you for sharing that.
Yeah.
Thank you for sharing that. So you also mentioned that you do assisted reproductive technology.
Mhm.
assisted reproductive technologies. What is that?
So yeah, it's a couple of technologies that basically just helps infertile couples achieve pregnancy or help them conceive, pretty much. So normally they'll define infertility as unprotected sexual intercourse, at least over a period of 1 year. Some I think recently they moved it back to 6 months, without pregnancy. That if you get married to someone and both of you have unprotected sexual intercourse for at least 6 months and there is no pregnancy occurring, then there is something wrong. All right. So then they'll start investigating. Perhaps there is infertility ongoing. Then they'll test the guy, check his sperm count, his health, his hormones. They'll check the lady as well, check the hormonal profile, pregnancy hormones, check the anatomy of the uterus, fallopian tubes, the ovaries. They want to know, does she produce eggs? Are the fallopian tube blocked? Are there fibroids in the uterus preventing pregnancy from happening? Are the hormones messed up? The hormones control a plethora of reproductive events, right? It's one hormones that controls the ripening of eggs and the release of eggs. All right. So if you don't produce a certain hormone that is supposed to help you produce eggs, you will never get pregnant until they actually treat that. All right. So they can actually regulate um, the imbalance in the hormone production. Same goes for the guy. There are some guys that when we do a semen analysis on their sperm, right, we notice that some of them um, have a low sperm count. And there is a threshold that we consider healthy sperm production. You should have at least a minimum of 20 million sperm, with about 40% of them being motile, progressively motile, all right, and having a good morphology, normal shape. Some people can have good sperm production, abnormal morphology. You see sperm with two heads, two tails, agglutination, clumping together. So those are issues that could prevent pregnancy from occurring. And even if pregnancy occurs, imagine a sperm with two eggs fertilizing an egg, it's going to create an abnormal embryo. And sometimes the body has a system in which it actually discards or spontaneously um, sheds progression and pregnancy for those kinds of implanted embryos. So there are investigations that we will do that would establish infertility. And once infertility has been established, then we'll now have start to try looking into assisted conception alternatives or technologies that could still help those couples achieve pregnancy safely. So then we start looking into, well, maybe we should try artificial insemination if there is maybe an issue with sperm getting to the site where the eggs are. We can directly introduce the sperm into um, the the entrance of the fallopian tube, for instance, and they can achieve a faster rate to pregnancy, right? Or if the fallopian tubes are blocked, we can do a surgery that would bypass the fallopian tube and harvest the eggs, and we take the eggs to the lab and fertilize them with the sperm in the lab in the petri dishes, culture the embryos, and transfer them back to the uterus between 5 and 7 days of incubation culture. So there are different technologies that we can adopt or use or that are available based on the diagnosis, the infertility diagnosis. Right, if it is male factor infertility, they could recommend lifestyle change. If it's low sperm count, right, take some vitamins, and do healthy living, exercise, supplements and things like that. Sometimes they help, sometimes they don't. Right, if it is issue of low sperm count, then we know that we have to use a specialized technology that will specifically take the limited amount of sperm and we directly inject them into the eggs. right? That's not a technology. But for those who don't even produce sperm at all, maybe it's obstructive azoospermia. Azoospermia is the technology we use for no sperm production. I mean, some people will think they produce sperm, they will produce an ejaculate. An ejaculate, I mean, it does the same thing as you having semen, I mean, sperm samples, right? So a semen sample is sperm cells and prostate fluid, like you studied prostate cancer, right? So
Yes.
the fluid produced by the the prostate gland, right, and other accessory glands. That is the seminal fluid, and it has its own function. Sometimes it helps to protect the sperm during, I mean, when it gets into the canal, the female vaginal canal. The female vaginal canal is known to be acidic, right? That has an acidic pH. You can imagine if you just introduce sperm cells bare like that with no seminal fluid protecting them, they're going to die. The acidic environment will kill them. So the seminal fluid is, it has an alkaline pH that kind of protects them from that acidic shock, right? And also creates an environment for them to swim in. It also nourishes them. It has food, glucose. That also powers the mitochondrial function for them to flick their flagella and swim into the cervix and find their way into the uterus and lay in wait for the eggs when they're released. So those things, they have to be known. All right. So if someone has azoospermia, they could produce seminal fluid or semen, all right, but without sperm cells. Then it could be obstructive. Then they can actually investigate and go directly into the testicles. We can get sperm directly from the testicles or the tubes that the epididymal tissues lining the testicles. We could also extract sperm from there. So depending on the kind of methodology that sperm is being extracted or retrieved, all right, we can say we are doing a testicular sperm aspiration, um, micro epididymal sperm aspiration, right, testicular sperm extraction, right. So those are, men with urological conditions whereby, right, they don't produce sperm or there's zero sperm count. We can access their sperm with a different medical technology, right? And the lady as well, we can actually help them to, produce more eggs, fertilize more eggs with their husband's sperm, and generate embryos that can potentially become babies. So that's the basis of what we do in IVF with regards to those myriads of technologies that we also assess to help people conceive safely and medically.
Wow. Wow. Thank you. Thank you. That's a very detailed explanation. Thank you for doing
Yeah.
that. I hope our viewers are learning and gaining a lot of knowledge from this. Now that you're explaining it very clearly, I understand it because I have PhD, and also you also break it down for people that probably don't have the degrees that we have. But then I also understand that people still have some fears around getting involved with assisted conception technologies. And with your experience, why do you think people try to stay away from it?
Yeah, I mean, it's very concerning. Prime number one thing, I mean, there's still some stigma associated with it. Back in the days in our country of origin, Nigeria, I mean, it's expected that everybody, I mean, they're expected to get married at a certain age, of giving birth to children at a certain age, that there's nothing that should stop you from being able to get pregnant as soon as you get married. In fact, from the next day, your family member will start asking you, "How far? How is it going? Have you gotten pregnant? Yeah, we just got married yesterday. Now it doesn't work like that, So it still has to take some time. So there's a stigma associated with it that everybody's supposed to be able to achieve pregnancy naturally. All right. But that's not always the case because biology differs, right? Some people, it might just be a genetic condition that suscepts them to that particular situation, So there is a stigma associated with it, and gradually, it's waning with education, with the light enlightenment, like what you're doing for your audience right now. Some people get to learn more about it. That hey, it's not a matter of stigma. It's a matter of you. It's just like if you're sick, you go see a doctor, and the doctor prescribes the right medications or treatment course for you to get better, right? So it's I don't want to call it a disease. It's pretty much a medical condition that just needs to be treated, and there is actually, I mean, viable treatment for it that people can opt for, right? Although IVF seems a little expensive in some part of the world, but come to think of it, Nigeria seems to be the cheapest place to get IVF done. All right, some parts of Africa, for instance, you could have clinics doing a package of IVF for as high as $30,000, and guess what? You can get same treatment for $3,000 in Nigeria, and from start to finish, you might not pay more than that. So it's actually accessible. Back in the days when I used to practice in Nigeria before I traveled to the United States for graduate studies, I didn't japa like they normally say now. I mean, you two, you didn't japa. We only went for graduate studies before the japa syndrome started. So, but then when we finished our graduate study, we decided to stay and utilize some more opportunities. But back in the days, I could count the number of IVF clinics we had in Nigeria, and they were not more than 20, right? Maybe less than 20 IVF clinics back then. That is 2010, 2011, right? Like how many years ago? 14 years ago now. But now, as at recent count, because we now have a regulatory body that governs the establishment of those clinics and the practices, not still well governed yet. There's still some lapses here and there, but it's much better than before. Um, I could count up to 100 clinics now in Nigeria, right? Even Canada doesn't have 100 IVF clinics. They probably have a little over 35, less than 50. All right. South Africa doesn't have that many, right? Or maybe close. All right. So Nigeria has quite a number of IVF clinics that are developing, also offering quality good services. So they call something now medical tourism, that even people who are resident in the United States can travel to Africa to go get an IVF treatment done because it's cheaper to access there. So, and now that there is a governing body regulating them, people are now getting more, how do I say it, more comfortable, trying to access it. It's not so much of a stigma right now. Some people even elect not to have natural conception. You know, I mean, super rich people here in the United
Yeah.
States, there are some models that don't want to mess up with their body's physique. That if I get pregnant, I'm going to lose my physique. I'm going to lose uh, income and things like that. So they elect to do IVF, get a gestational carrier to carry their pregnancy. It's going to be their eggs and their spouse's sperm, all right? But then they are using an external incubator, a human incubator, a gestational carrier, what we call a surrogate, right, to carry their pregnancy. And some people is because they can genuinely not carry a pregnancy. Some people don't have a uterus. They don't have a functional uterus. Or maybe they've gone through some surgeries in the past where their uterus has been messed up, or they actually had to take out the uterus for cases like cancer, all right, uterine cancer, for instance, where they have to evacuate, remove the uterus, all right, but then they can still maintain the ovaries. The person is still fertile, but they might not just be able to carry a pregnancy. So they can produce eggs, they can use their husband's sperm, make them embryos outside the body, and transfer those embryos to a gestational carrier who can carry the pregnancy for them to term when they get their baby after 9 months. So there are legit processes that actually favors people. And some people who delayed procreation to a later time in life. I mean, there are some people who didn't get married on time, and by the time they're ready to start having children, they were past the reproductive age. For instance, the cutoff for you being able to carry pregnancy in the United States, if you're above 50, 53, they won't let you carry a pregnancy because it's dangerous for you to carry a pregnancy at such advanced age. You could have cardiovascular conditions. I mean, there's been an incident whereby a lady was made to carry pregnancy around 50 plus years, actually got pregnant, delivered the baby, but a few years later died because of cardiovascular complications from the pregnancy. So it's a very dangerous event to attempt when you're advanced in age. So there is a cut of age. Even when people say, "Oh, I really want to get pregnant," the first thing we start with them is, "What's your age?" All right. There's even a cut of age where you can produce eggs up until. All right. So anybody approaching the age of 40, 41, 42, right, at those ages, we are already seeing a decline in egg quality. Not that you still not be able to make eggs, you can produce eggs, but the quality of those eggs are now being, they're not as good anymore. That even if we create embryos with them, the chances that there will be abnormal embryos is high. Right, so that will bring us to that level of we talking about reproductive genetics. Right, so we could create embryos by IVF. We could fertilize an egg with an husband's sperm with our assisted conception technologies, but it doesn't end there, right? So, as ladies age, I mean, from ages 35 and above, it's considered advanced maternal age, right? At that age, it's considered that the egg quality begins to, go down. So they also recommend that if you know that you're not ready to start making babies, all right, in your early years of marriage, it's recommended that you freeze your eggs before you start getting older, all right? Because the genetics of those eggs begin to decline, right? It's not about anything that you've done. It's just the principle of aging, all right? Aging in biology, genetic malformations, DNA breakages and things like that occur. And those cells are not as viable. So they recommend that freeze your eggs pre-age 35, right? If you know you want to have babies, make sure you get your babies done with your own eggs. They could still consider, some places could still consider you to use your eggs even till age 42, 43, all right? Sometimes even 44, 45, but the chances of success at those advanced ages are low. Right, so then that's when they now start recommending donor eggs. Right, donor eggs is that, I mean, you have it at the back of your mind that genetically speaking, you don't have any connection to that egg, right? It's not your egg, but you can um, believe it to be a kind of adoption, like you're adopting a baby that you're actually giving birth to yourself. So some people can settle with that. So that's part of the, the stigma that also arises with IVF, that some people want to not go for it, or be wary doing it. And there are some religious beliefs. So for instance, some religions believe that you should not play God when it comes to things of procreation. Right? I have a friend tell me sometimes, don't you think you're playing God, that you're actually creating life out of the body? I said, well, I see myself as a scientist, as a clinician, right? I'm like someone who is sick who goes to the hospital and gets cured by the doctor, right? I mean, in a way, we are also doing God's work. That's what I actually tell them eventually. So some religion don't believe in it, right? Some religion don't even believe in you doing family planning, all right? So, but we don't stigmatize those. We just take people for their belief system and let them do whatever it is they feel is comfortable with them. Some religions, all right, when they come to us for IVF, they have to monitor their eggs and their sperm. You know, like when we have to dedicate a special incubator for them, they will practically padlock their incubator or seal it shut, because they don't want a situation whereby there's going to be a mix up. Maybe they believe that someone's going to come in the middle of the night to steal their embryos, which is quite funny sometimes. But we let them do that, all right? So, and we accept them for their religious beliefs as well. So those are some of those things. Some religion are beginning to be amenable to the, the understandings that you give to them, like, okay, we can accept that you do this as long as it works for you, right? Some people have to go take permission from their rabbi before they actually proceed with IVF, which is understandable as well. So maybe with time, it will be globally acceptable. I mean, the penetration, they said there have been more than 12 million IVF babies born worldwide. All right. So more people are embracing it. And as soon as people get to understand their medical condition as it relates to infertility, or if they're trying to delay procreation, then they can as well embrace some of those available technologies that we have. All right.
Wow. Wow. Thank you so much. Very detailed.
Yeah.
Thank you. Thank you. So we have a question here from our association, Afrogrounds Abeokuta 96 Chedis. Said,
Okay.
you talked about age affecting women. How about men?
Yeah. I mean, age. I mean, it's not so much as in women than it is in men. Of course, with increasing age, men's semen sperm parameters also begin to decline. All right, concentration will decline, motility might decline. It doesn't mean that there's no sperm production in those who are healthy or still producing sperm. I mean, we've had cases that back in Nigeria, then before I left, there was a couple who came that the husband was 90 years and he still had sperm production and he still wanted to make a baby at 90. Of course, the wife will be younger, maybe like 30, 40s, you know. So there are some men that are blessed that they could still produce sperm. Their production, sperm production, and gametogenesis, all those hormonal systems are still functional even at older ages. But of course, the quality also matters. There are chances that you might have good sperm production, right? But then there's something called sperm DNA fragmentation, all right? The DNA of those sperm might be messed up. That if you use them to fertilize an egg, they will create an abnormal embryo that will not yield a viable, pregnancy. So, but then that's when some of those genetic testing alternatives also come in. So when we raise embryos for older people, like if a woman is above 35, we recommend that they do a test called PGT. PGT is pre-implantation genetic testing, right? And testing is for aneuploidies, right? It's not like you're checking a disease condition, but you're checking um, the number of chromosomes, right, that are available. We know that for every normal conception, right, the total number of chromosomes should be 46 in a cell. Right? There are instances whereby you have aneuploidies, so it could be deletion or addition or gain or loss of chromosomes. So they tend to analyze every chromosome from chromosome 1 to 22, including the sex chromosomes. All right, that's what those genetic testing do. So they assess, all right, is there a loss of chromosome in chromosome 18, chromosome 23, 6? So you get a detailed profile result, genetic result at the end of the day that tells you which chromosome is affected, which one has a polyploidy situation, right, where there is more than two pairs of chromosomes. So that will help us do a preliminary diagnosis to actually hierarchize the embryos that we create as to their level of normalcy. So we are able to tell which embryo is normal, which one is abnormal. So at the end of the day, when it comes to time to transfer back those embryos back to the uterus, we can know or go by those genetic testing profiles that this is the normal embryo to transfer that could yield a positive pregnancy, whatever chance you have in that clinic, right? So with age, men can still produce sperm, right? They could probably not be genetically normal. Of course, not all of them will be. It's a game of chance, right? If they do conventional insemination, allow all of the sperm that have been retrieved, as long as they have good motility, to just go by natural selection and go fertilize the eggs. Maybe the one normal sperm will do the job of fertilizing the egg. Or if you're trying to directly inject the egg into the sperm, once we choose, I mean, we just choose by chance as well, not that we know which sperm is normal or not. But at the end of the day, when we raise embryos, we genetically test them. And genetic testing means we take a piece of the embryo once it has grown at about day 5, day 6, or day 7. All right, and we take that piece and send it out for genetic analysis. They will do chromosomal analysis on it and assess whether it is normal or abnormal. So those are the options we do with age-related issues or couples considering IVF. But yes,
Wow.
men with age can still also make babies. All right, I gave you that scenario. 90-year-old man. I mean, we've had 70-year-old, 60-year-old. All right, I did a case recently. I mean, most of the time it's usually some people getting married again, maybe the third or the fourth time. And they're older, they found a beautiful lady they want to get married to. You know, in some countries, polygamy is not, I mean, frowned against. There are some religion that actually permits polygamy, but not in the United States, I know. You know, we have some Muslim friends whose parents married as many as three, four wives, you know, and sometimes. And some people, they legitimately would divorce the first, the second, the third wife, get married to one wife per time. And at such advanced ages, they want to consider IVF because it's probably not going to happen naturally at some of those advanced ages anymore. Right.
Hmm. Wow, wow. Thank you for sharing. That's really great. Thank you for
Yeah.
joining, Emmanuel Emmanuel Fadipe. Thank you for joining, my friend from college, from Obafemi Awolowo University. Thank you for joining. Now that we really understand a lot of things about fertility, one of the things you talked about is the spermatozoa not being able to move. And I watched a video about how sound waves can actually make the cells to move. And I'm not sure if that can also affect the sperm cells also. So do you guys do any research around that? Is that something that can be transferred to real life situation in terms of helping
Yeah.
a spermatozoa that is not able to move? Because the spermatozoa needs to swim, right? And
Hmm.
if it's not moving, it's a problem. I think a comedian said something about that's actually the problem that he had. I forgot his name. It's a white comedian. They said, well, his mom could not swim, and they couldn't do anything to that, so they had to do IVF. But then, is there any situation as to if transferring of that technology of sound waves into an alternative way for IVF, maybe for people that have religious reasons for not doing IVF?
You mean in vivo? That might be difficult. Yeah, I know what you're talking about. I think it's one. I went for a conference in Canada last year. I met one guy who gave us a talk about some of the technologies, additional technologies he's working on in microfluidics and
Yes.
um, ultrasound applications, right? So he's I think he's in Australia. I met him. He works with Monash University in Australia. Very sound guy. I listened to his lecture. Very brilliant. Blew my mind off. So I met him after the conference, and we further talked. And we might even collaborate on some researches down the line. So he's doing one interesting research whereby he's using ultrasound waves to wake up sperm that are non-motile. Right. One of the first things we also do when people want to come for IVF, before they even get to the stage of we even considering IVF, we have to test them. We have to check the status of their sperm parameters. So some people we know that they might have good sperm count, sperm concentration is not an issue, but then motility is an issue. So such situations where there's inadequate motile sperm, we call it astenospermia or astenospermia. So it's diagnosis that means that your sperm motility is less than I think 39-40% now. Right. So I mean one other the thing we like to think about right away is that okay we're going to consider this technology we call ICSI for them. ICSI is intracytoplasmic sperm injection, right? That all right for any individual who has a viable but non-motile sperm. Now, another thing is viability of the sperm. The mark of viability is that the sperm is moving, or sometimes it might just even be twitching, or or just be dancing on the spot. Of course, when we see such sperm, we try to avoid them because we think they're crazy sperm. So, but we like to see a sperm that is forwardly progressive, all right, that is moving and gliding in a forwardly progressive. I mean, it might be a forwardly up, forwardly down, right or left, whichever direction is going, as long as it's forwardly progressive, it's a healthy sperm, right? I mean, and healthy sperm is subjective because we still don't know what is going on inside with regards to genetics. So, this guy was actually specifically working on those situations whereby there's astenospermia, that is bad sperm motility. So I was trying to utilize the application of those ultrasound waves to, charge them and wake them up. And it was successful. And some of those sperm actually wake up. And some instances where we get to see that is when maybe a guy was diagnosed with azoospermia, which is no sperm count at all, and it's non-obstructive, and they have to go to the testicles or the epididymal tissues to actually source for sperm. The sperm that you take from the testicles or the epididymis, sometimes they are not motile sperm. It doesn't mean they are dead, but then you have to wait for them to wake them up. Right? Sometimes we process them in some media solutions that gives them some additional juice, and we incubate them, and we see that they are motile by the time we want to use them. Sometimes some don't even wake up at all, and we have to fish through a sea of dead sperm. And as long as we see even as the slightest twitching in one sperm, we pick that sperm, all right, and we use it. And we've had fertilization with such sperm. So this guy in Australia was trying to increase the chances of waking up those kind of sleeping sperm, maybe not dead sperm, with ultrasound waves, such that we can actually not have to exempt those sperm that we think are dead. Because in embryology, when we want to inject the eggs, we really have to see that the sperm is moving. Because if you choose a sperm that's not moving, it could be that the sperm is dead and the DNA has been compromised. It's not going to give you a good fertilization. Or even if there's fertilization, there might not be embryogenesis. All right. So the guys, I mean, it's still going to have to go through a couple of, FDA approval before they actually accept to admit our technology as with the other ones we're using. They have to check that, okay, the application of the ultrasound waves you're using, does it have any detrimental effect on the sperm? Right? Does it have any detrimental effect on the egg, so that in the future will not have woken up monster sperms and develop monster embryos or babies that will be genetically abnormal at the end of the day. So that is a viable technology that might, join our plethora of assisted conception technologies that we have already, and that could be also useful down the line. Now, of course, there are several other technologies that we can use. Some people, when they're trying to see which sperm is viable, some people fire laser. You use laser in a microscope at the tail of the sperm. When you fire the laser and it twitches and wakes up, it's a mark that it's alive, even if it's not moving. There are some chemicals that they can add, all right, to the media that we prep the sperm in. Pentoxifilin, for instance, would improve sperm motility. Some people, I met a guy who said a doctor prescribed some kind of cough syrup for them, because some of those cough syrup ingredients actually have some chemical that are material ingredients that actually wake up sperm and improve their motility as well. So sometimes maybe even coffee,
Coffee.
some ingredients, yeah, can actually wake up. It all boils down to triggering the activity of the mitochondrion. That's the energy house of the sperm, right? Whereby it needs to whip its tail and actually assume motion in that fluid-based environment, be it the seminal fluid, the culture media we're using to prep it, and so on and so forth. So yeah, ultrasound applications to improve sperm motility is something to look out for in the future, just like we mentioned.
Wow, wow. Thank you so much. Thank you for saying all that. So let's go a little bit to the side of the egg. One of the
Okay.
things that we really talked about that people have always discussed is egg preservation. What are the concerns that people have around egg preservation? Is it the way it's been stored? Is it the cost? Is it the fact that the baby that's going to come from egg preservation is not going to be as normal as the way it's supposed to be? Are there any concerns from the results from egg preservation after fertilization?
Not at all. I mean, um, egg preservation, as they call it, preservation of fertility. Um, Sometimes it could be, for instance, we have some patients or some clients, right? The mind of a patient, they've not found Mr. Right, okay, and they think they are getting older, right? And the biological clock is ticking. So rather than just let it go to waste, some of them actually get cancelled. Some of them it could be as a result of their own personal researches or recommendation by their OBGYN to go freeze their eggs. Right. So we still recommend that if you must do that, it should still be under age 35. But if you're freezing eggs above age 35, chances are that you have quality eggs is slim. Okay. So under age 35, you're not ready. Some people genuinely don't want to give birth yet because they just want to take time to focus on their career. They want to delay procreation, right? So when they are okay and settled and not distracted, right? So people like that, we encourage them to go freeze their eggs at an early age, right? But some people, if they think, oh, I'm almost going to hit menopause very soon, we still have people who freeze their eggs at age 40, right? A little bit above 40. I'm going to work on a case upcoming. I think, the patient is a little above 40 at the time of freeze. So, but then the limitation with that is even when we raise embryos, we recommend that they do that genetic testing again because with increase in age, there are chances that the egg quality also diminishes or declines. So, and it's also a game of numbers, right? So, if you want to freeze your eggs, the more number of eggs you have frozen, the better your chances. Because sometimes when we freeze the eggs and we try to thaw them, thawing them means that we want to bring them, warm them up back to room temperature and make them viable again. Sometimes some of them die. All right. Of course, there are thawing protocols that says that the procedure is very efficient and we can have up to 90% survivability rate. Right? That if you freeze 10 eggs, at least 9 of those 10 eggs will survive. All right, so that's a good mark of efficiency for that clinic. And sometimes, things can just go south. Half of the eggs could just die. All right, or even if they survive, maybe at the time of injecting them, some will still die. And so at the end of the day, irrespective of the number of eggs you freeze, right? And as some egg bank models work, for instance, some people actually buy eggs from the egg bank if maybe they have hit that stage of menopause where they don't have any more egg production going on, right? Like those advanced aged couples we have, maybe the ladies like 40 plus, there's no more egg production, or maybe they've hit menopause and they need to use donor eggs. Some can buy donor eggs from the egg bank, and some egg banks sell their donor eggs. They sell it in cases of I think six, right? Six donor eggs. I've seen prices of that as high as 15, $16,000. You can imagine, yeah, 6 cases of eggs. So it's very expensive. It's precious gold. So yeah, so some people and some egg donors will guarantee, they'll give a mark of guarantee that okay, for every 6 eggs you buy from our egg bank, we guarantee that you're going to have at least one viable blastocyst. So
Mm,
blastocyst is the embryo that has grown to a stage of um, where there's enough cells and it has blossomed and it's good, and the potential of that making a pregnancy is higher than all the cleavage state embryos that have not attained a blastocyst stage. So they will say that we guarantee that at least you get a blast from 6 cases of eggs that you buy from us. All right. The chances of a blast being transferred, getting you pregnant, At some clinics, it could be as high as 60%. All right, that if you transfer one embryo, the chance that you get pregnant with that one embryo, 60% of the time. Some it could be as high as 70%. Some it could be as low as 40%, depending on the age as well, right, of the egg, right? So, but for a young egg, I mean, at least you should get the gold standard statistics averagely at 60% or 70%, right? But if you're using your own egg at an advanced age, depending on the age, the chances of pregnancy begin to decline. For instance, if you're 40 and above, the chance of pregnancy is about 20% at that age if you had
Hmm.
used your egg. Right? If you're 37 to 38, maybe it's about 40%. 35 and below, then maybe it's at that 60%. So it all also matters depending on the age of the egg that's being used. But we recommend the more eggs you can freeze, the better for you. And at some advanced ages, like we had a case whereby the lady was, I think, 38, 39. She was trying to freeze her eggs at that age. And each time we do a retrieval on hour, we don't get more than three, four eggs, all right, per time. So out of those three, four eggs, maybe she would have two that are mature because it's not all the eggs that are produced that are mature. Some eggs still have to be thrown out because they are immature eggs and they can do nothing, except if you consider doing in vitro maturation on them, which is not very effective still. Right. So this lady that was 38, 39 years old trying to freeze her eggs, we getting about three, four eggs, I mean, each retrieval. Right. We had to walk her up to having frozen the last can maybe like 14, 16 eggs now. But she had to do that over 3 to 4 retrieval cycles. So maybe if she does a retrieval this month, she comes another month or 2 months time for her body to recuperate, does another retrieval, they get another number of eggs. You freeze that again. She comes another 2 months later, gets additional eggs frozen. All right. So up onto the stage where she's comfortable with number of eggs. Yeah. So 20 eggs, for instance, we'll say, all right, at chances that you get viable 20 eggs, you might get like four. All right. So from those four blastocysts, the one that will actually give you a baby will probably be two of those four, or maybe even one of those four, or sometimes, unfortunately, even none of those four at all. So it's also comes with a game of chance. With increasing age, advanced maternal age, such couples may need to go at it at several cycles before they get an adequate number of eggs frozen. Some just go or don't want to go through the stress, just go buy eggs from the bank. But then you have to understand that you're getting a baby that's not your genetics. But if you are able to handle the fact that maybe you're just adopting a child that you're actually giving birth to by yourself, then that's understandable. All right. So that's the way it works. All right. I hope I
Wow.
answered the question.
Yes. Thank you. So,
Yeah.
yeah,
All right.
so in case the egg gets fertilized, becomes embryo, there's something I also read about toxicity. All right, the fact that fragrance can cause toxicity in growing embryos. Are
Yes.
there evidences for this, and how what is the impact that can come from that
Yeah.
toxicity?
So when we work in an embryology lab, all right. So though I didn't really define those two sciences, I mean, andrology and embryology. Andrology is the science that deals with sperm, all right? Embryology is the one that deals with the eggs and the embryo. I mean, but we have overlaps all the time. Some labs they only have andrologists that only work with sperm. Some labs then they have embryologists that work with eggs and embryos. Right, but sometimes if they're well cross-trained enough, they can work in both ways. So one of the things we try to emphasize in an embryology lab is something called volatile organic chemicals or acids. All right, and those things could come from your perfume that you use on your body, the fragrance in your clothes. All right. Um, Sometimes it could be fumes in the environment. Maybe they just painted your office space. All right. So in an embryology lab, they invest heavily in an HVAC system. Right, that's the air conditioning system, and actually has some specialized filters tend to help filter out VOCs, volatile organic chemicals, because the slightest amount of those chemicals interfering with your eggs, right, that are growing in the incubator could actually create a toxic environment for them. But we have other um, protocols and methodologies that we use, right? For instance, dishes that we culture eggs in, we overlay them with oil, right? Sometimes the oil is just to maintain temperature, maybe pH, maybe to filter off chemicals, but they can still get in, right? They can diffuse in, right? So some of the things we watch out for is the VOC levels in the lab. It must not um, get to get above a particular threshold that is needed, right? Because if it's too high, then you begin to see decline in fertilization rates, blastulation rates, even pregnancy rates can be impacted up onto live birth rates. So yes, indeed, like I for one, as every embryologist, we don't use perfumes to work, right? Because we cannot use roll-ons, colognes. Or even if you use roll-ons, it has to be a non-scented one, right? Well, a non-scented colon or roll-on, right? But you cannot spray yourself heavily just because you want to smell good, because the eggs are very finicky, right? They are the most delicate cells we work with in the lab, right? You have to work with them very carefully. If you um, if you handle them roughly, they'll die. If you inject them roughly, they'll die. If you expose them too long outside the incubator, they'll die, you know? So that's why we have protocols we follow. You cannot work on the eggs more than a, a permitted period of time outside of the incubator, all right, without adequately buffered media. So when we are working with them, the media we use, they've been buffered with the appropriate pH, because if there is disparities or changes in that pH as a result of you working on them too long outside of the incubator, you get bad outcomes at the end of the day. So yes, it's true. Volatile organic chemicals, right, can become toxic to the proper um, physiology of the eggs, and they could actually contribute to bad outcomes happening when they get exposed to such kinds of chemicals in the lab. All right.
Wow. Wow. Thank you so much. Thank you. This is a you're lecturing us, so you know that you're a professor, right?
Yeah,
We are your
let's
students for
see.
today. Thank you so
Yeah,
much. Thank you for sharing that.
yeah,
One of the things that we mentioned earlier on was paternity in Nigeria and how that has changed over time. I want to understand more how that has changed. I read somewhere that in the past that when people want to do paternity tests in Nigeria, they send samples abroad. Is that
yeah,
true? And
yeah,
how has that changed now with next generation sequencing? That is now a common thing.
yeah. So back in the days, even up until now, only there was a lab, I think that Lagos state government started back then, that does this DNA forensic testing. But it was only until recently that we got to know that maybe they don't even do all the testing there. I don't want to misspeak so that I don't get flagged in case your video goes viral. But like, I was very happy to see that development by the Lagos State. That was the first DNA forensics lab that would have been established. It was many years ago. I used to follow them and probably maybe even try to reach out to them sometime. But when you don't have a name, they don't even answer you. So, but that was when I was working as a DNA technician at my DNA lab in Florida. But then it was later on I got to know that even when they need it for to conclude a case with law enforcement, they still maybe need to send a sample out, or maybe that the technology was not that adequate still. Right, so I think back then they used to do this capillary electrophoresis to assess the short tandem repeats that are being amplified from those cases. And then yeah, they might be able to do that, but then you might need next generation sequencing for parallel amplification, and things like that. So it's a more, you know, um, higher advanced technology, all right, that my friend's lab is the first to start, where I'm the chief scientific officer, right? So then they compare when they do paternity testing. They are not into DNA forensics for law enforcement applications now. They are not doing crime scene samples yet. But what they are doing is they are trying to just do paternity testing, which is another aspect of forensic DNA analysis. So they just try to match sample of a child with the father and try to see, right, if there are, matching alleles, right? The hypothesis for a diagnosis or a conclusion is that if there are no two mismatches, then potentially maybe 99% of the time the paternity is the father's, right? But if there is more than two mismatches, so then there's a question that okay, the paternity of this sample or this child is questionable. So yeah, I mean there are newer technologies that could actually help to refine and get a test to a more acceptable level. Because everything is still based on statistics. You could get a 99 chance that the paternity is the father and it could still be wrong,
Mm,
and some instances, I mean, if you're dealing with a twin situation, which I mean could not really give such levels of high incidences or rates like that. So yeah, they used to send samples out, right? Because the technology needed wasn't maybe affordable by those organizations and institutions back then, but they were still doing it. I mean, a couple of labs sprung up even in Abuja area that I used to read about that do all those paternity testing. But
wow.
oncogenomics lab, which is my friend's lab, when we actually worked together at the IVF clinics in Lagos, then he delved
Mm,
into paternity testing. He's doing all manner of testings now. So he is the first to actually use next generation sequencing. He got the Illumina MySex or Forensex is the
mm,
equipment he uses to help do parallel amplification. You actually get to the raw sequences that you can analyze, and they have specific markers that they
mhm,
target. All right, and it's doing pretty good. So I go through their results at least every now and then that they have samples to work on. They pass the final results to me just to help them evaluate as well. So and they're doing pretty good. So at least I mean, in Nigeria, at least I know that there is a lab. Now we want to see how they can collaborate with other advanced lab where they can actually even do more testing, maybe get into crime scene investigations as well. They could be useful for the courts so that they don't wrongly accuse someone who is not, who wasn't at a crime scene, but that
mhm.
has just been labeled or picked up by the police, just so that they can close the gates. If there's no if there's no DNA sample to actually exonerate them that I wasn't at the crime scene, I didn't contribute to that. So many people have actually had wrong convictions by the court. So DNA forensics is, I mean, the next level of you actually doing the right justice, right, for the masses as well. So
Yes,
that's why some
yes,
of those labs are springing up. Yeah. Mhm.
yes. I mean, that's very important you share that because even here in America, we have cases of people that have been in jail for 30 years, and after 30 years, you just found out that they were not they had the wrong
Yeah.
person. And like,
Their DNA samples exonerated them. Yeah, the DNA technology itself is pretty new. When we're doing biology, Watson and Crick, when did they discover DNA? 1960, right? So, and
mhm,
even before they knew the structure of the DNA, but before the technology started springing up, like PCR technology, where they used to amplify DNA, that didn't happen until like 1980s. All right, so 1980s, 1990s, the right equipment that are needed for you to sequencing the DNA sample, you know, before they were able to do the map the human genome. It wasn't until the 2000s, right? So it's a pretty much new technology that is still advancing. But then so many wrong convictions have happened in the past that their DNA could have exonerated them. And that's why some of those DNA tech applications are now springing up to help the criminal justice system to also help efficiently do their job well as well. Okay.
Wow. Wow. Thank you so much.
Yeah.
There's something that you shared earlier on sperm donor and also egg donor. In case we have audience here, because you mentioned some numbers, it seems like people can make money from this, right? What are the what are the things they need to do? In case somebody is hearing there and say, "Well, I want to make some money with donating egg or donating spermatozoa,"
Hmm.
how can they contact you and what do they need to do?
Yeah, I mean, I like to tell people I'm not in the business of selling body parts because I can sell it to body parts. Normally, even if you're donating eggs, legally speaking, because there are some legal aspects to it, they won't pay you for the sperm you have donated or the egg you've donated. They will say they are just paying for your time, right? Because it's illegal to sell body parts and they consider human gametes to be body parts. I almost
Hmm.
thought about it of starting an egg bank in Africa because when I heard how much you sell 6 cases of egg for like 16,000 right? And then sometimes they pay the donors, the actual donors in the United States, maybe not more than less than $10,000, right?
Hmm.
And it's not because of the fact that they got 6 eggs from that donor. They might get 20 eggs from one donor and split that 20 eggs into three or four. I mean, sometimes it could be as high as 30, 24 eggs. And so that means that from a case of 24 eggs you got from an egg donor, you could sell maybe up to $90,000 worth of eggs, right,
Hmm.
from that. So it was kind of like, wow, this is quite lucrative for some people. I still had conflict in my mind that I'm not sure I'm going that kind of business,
Yeah.
because even in Nigeria, they don't pay them that much. I mean, back in the days when I was working at one fertility clinic, maybe they paid egg donors 100,000 or,
Hmm.
I mean, high enough, maybe 150, 200,000. And then the IVF cycle, then I don't think it was up to a million back then, but it was, I mean, almost close. So the disparity with regards to payment or remuneration for those donors is low. I mean, the sperm donors are even worse. If you want to donate sperm, back then maybe they give you 1,000 naira for the sperm you have for the sperm you have donated. So I mean, in the United States too, sperm donors are, yeah, they don't pay them more than 1,000. I mean, they don't even pay them of that. The sperm itself, when they freeze and sell the sperm, you can't get a sperm via more than $1,000. I mean, that's the premium, most quality sperm, all right, expensive ones that you can get. So yeah, there is a market for it. I mean, some people donate their sperm, just to make some more money. Some students do that. But then the problem is when you start having, I mean, people using those DNA testing come like 23andMe and Ancestry DNA knocking on your doors in the future. I say, I think you're my father. You donated sperm to so and so in the past. And you have a couple of children that you don't know you had now trying to find you in the future. So you have to understand, the implications of that because I mean, in the near future, the world will be so interconnected that DNA will be like another social media that you can connect yourselves. You can tell who is really your relative, right, and who you are really connected to based on your genetics, and things like that. So, yeah, there are programs that recruit egg donors. Right? My clinic in the US, we have in-house egg donors. Some people actually, for instance, we have a program in my clinic whereby if there is a couple who cannot afford the IVF treatment, so they recommend to them that they can do a shared donor program whereby they can donate some eggs to a couple who can afford it, whereas that couple will not pay for their treatment cycle. So there are programs like that allow some people. I'm not sure they do that in Nigeria yet, but yes, there are programs that recruit egg donors, but then they have to properly educate those egg donors. In some instances, they don't recruit an egg donor if they have not had a child of themselves by themselves before. Because you don't want a situation whereby, oh, someone has donated eggs, and when it's time for them to start their own family and they cannot have, their own babies, then they start thinking, oh, I've donated to family before in the past. Of course, all those things are anonymous. You don't know who you have donated for in those programs, and it's legally, stated that you cannot lay claim to those biological materials anymore. All right, you've donated them. It's no longer yours. But then the new technologies of today still finds a way to locate people by their genealogy. So it's quite dicey. I'm not sure I want to go into an egg donor business or company. I almost tried starting in the past.
Mhm.
I talked to a reputable egg donor agency that, okay, we could actually have an egg bank in Africa, and where we could actually help people, get their own eggs. But I just said, no, I don't think I'm interested in that. I would keep doing the science part of helping people to achieve consumption, right? Helping in the lab and things like that. But for it's money that I might be interested, maybe as a means to get additional income. I've had some students, I've had past students tell me that, oh, they've been an egg donor before. I asked them, how much did they pay? They pay me like $6,000. Now that's free money. But yeah, free money then, but then implication in the future, when those babies start looking for you, you want to deal with that? That's another thing. So, yeah, so it's possible as a means of income to some people, but then you have to know the downsides as well. You choose
Yeah.
to go
Mhm.
that route. Yeah.
So now that you share that, the implication of that, now we have to suspect people that are saying that they don't want to have kids. But then you said that people that don't have their kids, you guys don't deal with them, right? They don't donate because you have to have your kids first because before you can donate your egg, right? That's what you said, right?
That used to be the criteria in the past. They don't go by that anymore. Anybody who wants to donate, irrespective of whether you have had a child before or not. As long as you qualify, they'll do all those FDA testing for you, ensure that you don't have any infectious disease and things like that. That means they would recruit you to be a donor. I was saying that back in the days when the regulations are very stringent in Nigeria, that before they recruit an egg donor, it has to be someone who has preferably had a child before in the past, so that in the event that they want to start having a family in the future, they don't think that, oh, I donated eggs, let me go get my eggs now, and go to
Yeah.
court and fight. But then it's not going to be possible anymore. So
Wow.
nowadays, there are some people who said, I don't even want to get married, I don't want to have babies. I have friends like that who say, I'm not interested in marriage. I could have my own child. We have single parents, like single ladies, single men, in fact, who come to our program or our clinic requesting to have babies. There's everybody is, entitled to a family as long as you've gone through the psychological assessment process and you know what you're going in for. Even single ladies can buy sperm from the sperm bank to make babies by IVF. Single men would get themselves egg donors and gestational carrier, right, to actually um, get themselves babies. They don't want to get married. They don't want the hassle and the stress of marriage. Some say they don't even want a baby, but they would rather just donate their eggs and their sperm as long as they're helping some couple to make babies. They're satisfied.
Wow.
I mean,
Well,
everyone
you
to his own. Yeah.
and you guys are not allowed to ask them why. You just do whatever they say they want, right?
No, 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 we ask questions before you go into any, because you are medically bound by regulators. Like for you to even start an IVF clinic is a it's a stringent process. We have to pass our board exams first before we, the embryologists, can work. You have to be licensed by the state before you can work. The doctors, I mean, any OBGYN doctor has to pass their boards. And it's not just OBGYN doctors that work in IVF clinics. They have to be double board certified as also a reproductive endocrinologist dealing in infertility. Right. So we go through these hoops and stringent regulations so that we don't just indiscriminately, raise embryos or babies for cycles. So sometimes those people have to go through psychological evaluation. They have to go through psychologists and therapists, assess their level of health, that they are of a sound mind, and they can actually take care of a child,
Mhm.
father a child, or mother a child, right? So, and that goes for those single parents who want to do that. So they make them go through some of those psych evaluations first before they are cleared to have an IVF program with us and things like that. At least that I know for some clinics that I work for. Sometimes we in the lab don't deal with all those extraneous events. We just let the clinical team deal with that. I mean, there are other departments that actually work on the fertility nurses, the medical assistants, and those other people. They deal with all those other sections that has to be passed before they now graduate to the level of we being able to raise embryos for them.
Wow,
Yeah.
wow. Well, thank you for sharing that. There's something that just came up twice now. The way the spermatozoa behaves while you guys are in a center, you're looking at it under the microscope. All right.
Correct.
So, are there any study or evidence stating that the way a spermatozoa is behaving while you're looking at it under the microscope is a projection or an indication as to how the individual that's going to be formed going to behave?
Hmm. Good question. I know I've stumbled across some studies that are trying to assess and evaluate such. We call them maybe kind of epigenetic factors, how the environment impacts fertilization events, maybe even embryogenesis and things like that. But I mean, left to what we do in andrology, as soon as we collect this semen sample from an IVF candidate, we still have to process it. All right. And it's not like we're going to use your raw sperm like that. No, it doesn't work that way. Of course, there are devices or technologies that we can use a raw sperm to prep. All right. There's a microfluidic device that one of our professors worked on. Remember Dr. Asgar?
Yeah.
That device got sold. That device got sold to another big fertility company for a
Mhm.
couple of, I think, it wasn't disclosed, but I tried looking for some numbers I got could be in the hundreds of millions of dollars. I
Ooh,
told him that he should just go and retire and buy a
wow.
private island somewhere, you know. But, but I'm not sure he got so much money because it was his PhD doctoral, I mean, research. So he probably might not have a lot of stakes. It's going to be his PI that started the company that will make a lot of money. So we can flow a raw sperm through some devices and get a well prepped sperm that we can directly use for IVF or ICSI or whatever tech we want to use. But for the conventional method we use, when we get a sperm sample from an IVF candidate, first of all, we wash it. Washing means we separate the seminal plasma or seminal fluid that will contain some debris, maybe even bacteria, you know, so at the end of the day, when we finish prepping the sperm, we have an absolutely clean sperm. It's not that it's going to be devoid of things like viruses because our methodology cannot filter out viruses because those are ultra microscopic. But you could get rid of bacteria, debris, other materials. By the end of the day, we have a well prepped, clean sperm. Sometimes the motility would even have improved at the end of the day because we also try to incubate them slightly depending on the tech we're trying to use for that treatment. So yeah, I mean, with regards to being able to tell how the outcome is going to be based on the morphological characteristics we had observed, that will be difficult, all right? Or there are some things we like to see, all right, when we are prepping the sperm. At the end of the day, when I prep the sperm, I want to see a fully progressive sperm. Of course, when we are trying to do a technology like using ICSI, where we inject the sperm directly into the egg, we use some media or drops or chemicals, not chemicals, like media that slows the motility of the sperm so that when we are picking them, they are not running away from us too fast. We can quickly immobilize them. We call that drop PVP. It slows it. It's a highly viscous or dense. It's of a higher density, and it actually slows down the motility so that we can easily go after and quickly assess the sperm morphology because that's one of the things we also do. We have to be able to assess that the sperm we are picking is normal, has the right shape, head morphology, neck morphology, tail morphology. So we can see those three things quickly at a glance before we pick them. And even at that, we still have incidences whereby we have abnormal embryos being created because, yeah, you're seeing a seemingly okay sperm, but you cannot see the DNA inside. You don't know if the DNA is broken, if it's damaged, if it's abnormal, right? You be a celestial entity for you to be able to determine or see that. So we just go by what our judgment by sight can tell us. And we expect that the embryo that gets created from that should be almost close to normal. But then the genetic testing would also help us shed some more light as to what we could not see at that point in time. And that would also help us or inform us as to which embryo to finally select that will potentially yield or give a viable normal pregnancy and end up in a live birth of a healthy baby.
Wow, wow. Thank you. Thank
Yeah.
you so much. We're wrapping up.
Okay.
We're almost going to be done. You're probably going to be the longest session that we have, which is really
Yeah,
good.
reproductive matters are interesting matters. Yeah.
Yeah, yeah, this is very interesting. I'm learning a lot. Even
Mhm.
though I have a PhD, but this is not my area of
Yeah, field. Yeah.
specialization.
Mhm.
So one thing I really want you to share is one particular successful story from assisted reproductive technology that comes to mind. Which one of those story really excites you about this job that you do? That you're, oh, we were able to help this person, and this is how it went. They thought they wouldn't be able to do this. What? Which one of them excites you the most?
Oh yeah, a couple. I mean, several. Mm. Right from the days when I started as a young man, I think I started IVF as a 22-year-old back in Lagos, Ikoyi. I want to mention that clinic, the popular clinic in Lagos there. Right, so the first procedures I used to do then that they let me do because you still have to be trained in it is the one that deals with artificial insemination. It's called IUI, intrauterine insemination. So I think I used to post then. And yeah, Olumide, how did your case go today? And we are going in the staff bus back. And Martin found you missing. I started impregnating people. You're not laughing the bus. What do you mean that you did this, but you're not serious? It means that I started achieving success, with some of the technologies. So it starts with me just being able to prep the sperm well, and the doctor will inseminate, will load the sperm in some special catheter, they will deliver it into the uterus. And as simple as that, the ladies will get pregnant. There are some people, they don't really need to go into the deep, highly expensive IVF part that costs millions of naira in Nigeria or thousands, several thousands in the United States. All right. Some people it's just a case of unexplained infertility. There's nothing wrong with the guy, there's nothing wrong with the lady, but they just can get pregnant because they've been going through, unprotected intercourse. So sometimes they help them with simple procedures and IUI, Okay, we will wash the sperm, concentrate them, and deliver them directly to the entrance of the uterus or the fallopian tube, whichever one the technology can afford. And people get pregnant. I had a couple of pregnancies in Lagos then. Now, when I started practicing as a full embryologist in the United States, we've had a 53-year-old lady come to us, wanted to get pregnant. Of course, at that age, she couldn't use her eggs anymore. She had to use donor eggs. Raised donor eggs for her, and she got pregnant at age 53. That's like a miracle to me. So we have cases like that. And there's one unique case of a patient we're working on. This will might blow your mind. At that age, also around age 52, 53, of course, she's hit menopause. And then her daughter donated eggs for her. So she wanted to use her daughter's eggs to create embryos with a new husband, which is kind of gray area, but as long as their clear consent has been taken, they can do that, all right? Some people will say, oh, that's, an abomination, blah, 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 but none of that is our business, really. So as long as they pass all the, required protocols and all that, and consents have been taken. So I think the lady actually got embryos made. She got pregnant initially, but I think maybe it got lost, and she tried again. So we've had cases like that, whereby sometimes it doesn't happen at the first time, it might be the second trial, or sometimes even the third trial. We've had cases as many as 7 trials before they got pregnant. So there are some other underlying factors. IVF is one thing, but it's not the be all end all. You could actually raise embryos for a couple and still not be successful, all right? And they would just not want to give up, all right? Sometimes it could be a situation with the uterine lining. It could be a situation of, mixed up hormones, all right? Other underlying conditions or sicknesses or diseases. For some people, they just keep going. They get encouraged. They have good support system, and they never just give up until they achieve their goal of having their own pregnancy, getting their own baby. And when they look back, they say, "Wow, it's all worth it." That and they tell us their thank yous as well, and it kind of gets fulfilling for us. That's where the joy. And when they share pictures of babies that I
Mhm,
created in the lab, when I begin to see those beautiful, chubby, fat, chubby, beautiful
mhm.
babies. I'm always happy. I say, I know when this child was conceived. They were conceived
Yeah,
right in the petri
because
dish in the lab. That we facilitated their conception in the lab. We assisted them. Now, and when people are saying, "Yeah, playing God," I say, "No, we are not playing God. We are only assistants here. We are assisting. We're doing God's work." Because some people will also say you cannot help God in any way. So yeah, we can, but we are also doing God's work. It's kind of a fulfilling, purposeful thing for me to do. That's why I'll probably still keep doing this even while I'm teaching. I'm a retired teaching full time, but I think
Mhm.
I'm still going to hold on to my clinical embryology thing for a while, even,
Yeah,
and I'll still maintain my teaching assignments as well. So
yeah,
it's
it's
quite
very
rewarding.
exciting.
Yeah,
Hmm.
very exciting and important. Yeah,
Yeah, there's something I almost forget to ask.
yeah,
We've talked about infertility, right?
yeah.
How assisted reproductive technology can help. In the
Hmm.
case of sickle cell trait, how
Yeah.
can assisted reproductive technology help?
That's another thing, yeah. So I talked about that genetic testing that only assesses chromosomal balance by checking for nucleus. There's another pre-implantation genetic testing for diagnosis, that is usually used to diagnose monogenic diseases. So there are certain monogenic disorders that is peculiar with um, reproductive medicine. For instance, we have some couples who come to us. They are not infertile. They are normal. They're okay. All right. But then they've done their genetic assessment or genotypic assessments, and they've been determined to be maybe a carrier of the deadly or debilitating disease like sickle cell. Right. Like I used to tell people, my wife and I we are both sickle cell carriers. All right. We have the sickle cell trait, not that we have the disease. So I'm AS. My blood hemoglobin genotype is AS. My wife's is AC. So she has a different allele strain. So right from the onset, before I got married, I was hell bent on we are going to have to do IVF if this marriage is going to happen, and we're going to have to do that pre-implantation genetic testing for monogenic disorders like sickle cell. But somehow, I mean, my wife agreed and said, no problem, we'll do that. But when the time came, I mean, we just got pregnant, we didn't even know. But we're thinking that if worse comes, if push comes to shove, even if we got pregnant, we eventually have a sickle cell baby, then we'll consider other treatment, alternatives like bone marrow transplant, um, all these CRISPR technologies now happening, although still, in progress. I would probably need to consider that. But I mean, as God would have it, both our kids did not have the sickle cell disorder. We were just lucky, maybe. But
Yeah.
that was the basis of my doctoral program. I was trying to design a technology for myself that could help me identify sperm that probably has sickle cell or some other kind of genetic disorder. It's not just sickle cell, there's also cystic fibrosis, which is common in the Caucasian population. Sickle cell is just common in the African population or African American population. Back in the days, the statistics used to be at least 1 in 4. If I get it, 1 in 4 people has the sickle cell trait in Nigeria, right? So that's why they always recommend know your blood genotype before you get married. If you're AS, they'll tell you not to marry another AS. If you're AC, don't marry another AC or AS. So, but me, I'm in the field. I'm knowledgeable about it. I know what I can do not to have such pregnancies. But then it also comes down to affordability. It's not that cheap. You trying to do that kind of technology, it's not. It's one thing to raise embryos. That costs like 2, 3 million naira in Nigeria, for instance, or $30,000 in the United States. And after that, go to the level of PGT for monogenetic disorder diagnostics. That's another 3 million naira in Nigeria again, like close to a total package of 7 million naira to get IVF and do genetic testing. How many people can afford that? You have to be super rich. And it's not that when you do it once, you achieve success once. You might be doing it 2, 3, 4, 5 times before you get the required result you're looking for. So who has 30 million naira between IVF and PGT up until when they're able to get a normal, healthy birth? So it's difficult. So and it's not readily accessible. So I was thinking of a technology that I could do, right, which is what was the basis of my PhD studies, that I could actually select sperm and tag some of the expressed proteins with certain monoclonal antibodies that could help me delineate which sperm has a sickle cell gene, which doesn't have a sickle cell gene. I was also used another model in cystic fibrosis. Then we also did X-linked disorders because there are some genetic disorders that are also ascribed to the content of the X chromosome, which is usually, definitely from the mother, and the father can also contribute that. For instance, some people that have the blood clotting factor, hemophilia, and other diseases, they also come to us for IVF because they've had an history of that in their family. They don't want another child that'll come down with that. So we actually can help them select the embryos via that genetic testing protocols that would tell us the information on that embryo before it is being transferred. So we can know which embryo has sickle cell, which one is us the carrier, which one has hemophilia, which one has cystic fibrosis, which one has, just about any kind of genetic disorder that has been probed, right, that has been previously worked on. We can pretty much do that as well, even in our assisted conception protocols as well. All right.
Good. Good.
Yeah.
Thank you. Thank you for sharing that. That's very powerful. We're wrapping up. I promise you. Like two or three questions more.
Okay.
One question I really want to know: what are the government's regulation around in vitro fertilization, intracytoplasmic sperm injection? What are the things to watch out for? What can be done? What cannot be done around all these techniques?
Yeah, I mean, that's another very important question. For instance, for any IVF clinic to even operate here in the United States, you have to be licensed, right? So there are different regulatory bodies that we go through. There's CAPS, there's JCO, right? Um, so normally every 2 years, an IVF lab has to be reevaluated and reaccredited, basically. All right, and that's not even to do with the Florida Health Board because I'm in the state of Florida. All right, so every clinician has to be licensed by their respective board. For instance, I'm licensed by the board of Florida. They're called Florida Board of Clinical Laboratory. I mean, clinical laboratory personnel. It's a long name.
Mhm.
Florida Board of Clinical Laboratory Personnel. There's a Florida Board of Medicine, Florida Board of Nursing, right? So for every group that works in the IVF, like the nurses, the medical assistants, the doctors, they all have to be board certified. I mean, some people might just be on their way getting there, sometimes some embryologists are still in training, but they still have to be under supervision up until the point where they get their board certifications and their licensure. All right. So every IVF clinic has to be, reaccredited every 2 years. Right. So the accrediting body will send their inspectors. That's what they're called. Right. So they will go through all of your SOPs, your manual, your quality control papers and assurances. So they will reevaluate everything book page by page just to ensure that you're working up to standard in the industry. Of course, there are still lapses here and there because we get to hear of all those lawsuits like there's a wrong embryo being transferred, there is a wrong sperm being used. I mean, those are human errors. And because, I mean, when we are doing those board exams, we take those continuing education courses that we have to pass as well. One of the things we also work on is human errors or something. I've forgotten the title of that's the course that we have to do. So, and there are mitigations in place. For instance, there is a technology we also use in the embryology lab that is called it's a witnessing application. For instance, before I get to inject an egg with a sperm, I have to have an assistant, a second embryologist or andrologist that will ensure that they witness the sperm I'm picking that I'm taking from. They check the name, they check the label. I say, okay, I'm about to inject this egg with so and so sperm. Can you ID the name for me? So the person has to witness before we use. So there are instances where maybe there are not such checks and balances in some labs. Maybe the embryologist has been overworked, all right? Or maybe they don't just have adequate number of staff that is supposed to work in that clinic, for instance. So there are instances where some errors might be made indeed, but then when they start auditing them, they start finding the loopholes that, okay, you didn't go through this step, you didn't witness this step. Maybe that's why the error occurred. And it goes into several millions of dollars in lawsuits sometimes. So, I mean, the prayer of every embryologist is never to make a mistake. But mistakes are sometimes, I mean, they sometimes happen. But we try as much as possible to do our best possible not to make such mistake because they could be fatal. Imagine you being a black couple and you discover that you're giving birth to a Chinese baby, so you're giving birth
Mm.
to a white baby. Start asking her, madam, what happened? Did you see another man during the process, and things like that. So it's always very challenging. And when the investigators get to pinpoint it down to the IVF lab, then it becomes a big legal suit. I mean, and so many bad things happen. So we used to feel bad for labs and embryologists that maybe have fallen, I mean, short in some instances. But then we come to be compassionate that maybe it's just a human error that could just have been avoidable. Maybe if the right technology was in place or the right witnessing was in place, and things like that. So errors can occur, but the rate at which they occur should be minimal I mean, even close to zero, you shouldn't have any critical error, all right, like that happening in the embryology lab or an IVF clinic at that, because it destroys reputation. You know, some clinics have to shut down. Of course, nobody's going to want to go to that clinic anymore because of the bad PR that it generates and things like that. So that's why even the United States is trying to see what other regulations they can put in place. Maybe at the end of the day, they'll mandate every clinic to have a witnessing application in place, such that even if there's not a second embryologist, when we are trying to do some procedures, because we tag our dishes with RFID chips and the tubes as well. So when you're trying to go to the next stage of insemination, injection, and you go through all those protocols, if you bring a mismatched embryo or something that doesn't belong to the patient you're working on, the alarm bells will go off. So you're immediately being, drawn back to recheck your process and ensure that you're doing the right thing. So such texts like that may be mandated. All right, and there are texts like if you're freezing an egg so that you don't wrongly choose an egg or biological material that doesn't belong to the patient. They also have those devices we use to freeze them. There's a tech that has RFID chips that actually would alarm you if you have maybe chosen the wrong embryo or chosen the wrong egg in that instance. So there are technologies that could also help in those regulatory processes and affairs down the line. But they always warn us and train us to be highly meticulous, at least in that field of practice that we work in clinical embryology and andrology. Right.
Wow, wow. Thank you so much. One thing I really have to ask is when you had the interaction with international institutions, World Health Organization, and African Development Bank.
Yeah.
What are the lessons you've learned from this interaction? What are the big takeaways you'd like to share? And
Yeah.
how
My
can yeah, go ahead.
yeah. Sorry to cut you off here. My interaction when I worked with WHO, it was even in Nigeria. I worked with them as a visiting intern. And it wasn't even, of course, I worked in the unit I worked in with WHO back then. That was back in 2013 ish. When I traveled from the US, I was doing my master's program. So I went on for summer that year. I'd, of course, been communicating with the country representative of WHO in Nigeria. I wanted to go back home. I like to travel home at least once a year to go give back. And that's why I don't like people who just bash their country and say, oh, that country can never be good again and blah, blah, blah. Take your bags and jet off. I'm a little bit reserved as to when they say that because you never can tell. You can still help a nation. Of course, you might be living in another advanced um, economy or country, but it doesn't mean that you still cannot give back to your home country. So I used to travel home. So I went back home to work at the WHO back then. Even when I entered the gate, oh God, how did you get here? They don't just admit people to come and work in this industry. You must know the president, or you must know one minister that brought you. I said, I don't know anybody, and I just email me. I send them. And so I was posted to they call it MNCH, maternal newborn and child care health or something. So that's the department that deals with women and children, basically. That's where you have the OBGYNs work too, and anything related with reproductive medicine. The WHO is pretty much like a big, I used to see them as a big Ministry of Health back then, but just with international affiliations. So I worked with them for like a couple of, even maybe 2 or 3 months back then. So even while I was there, I did a project that the WR, the country representative, funded. They actually earmarked funds for me to go to that study. I went to UCH in Ibadan, and I went to OATHC, your university's teaching hospital, to go gather some studies. I was trying to see the knowledge and perception of pregnant mothers on available technologies to mitigate things like sickle cell. So we're trying to see what's their knowledge about bone marrow transplant, prenatal testing, right, for those at risk groups like that. So it was a very enlightening phase. At least it entered my CV that I also work with the WHO. Of course, we maintain some networks, some communication still with them. Even up until now, I still have friends in WHO that I can easily call and work with. Right. So that was that about that. Nothing serious about IVF. It was just public out, um, studies or engagement in maternal and child health scenarios. Then my stint with the World African Development Bank, that wasn't even with IVF as well, because I still do my clinical microbiology studies as well. So we were involved in public health, infectious disease research. That was during Ebola, and even more as recently as during COVID. So we're trying to introduce new technologies that could help us diagnose Ebola faster and COVID faster. We're out trying to help introduce this LAMP technology, a little bit different from PCR. You don't need
Mm.
to buy that expensive PCR machine. You can even just do your DNA amplification in a water bath or a heating block. One step temperature, and you can have amplified um, targets that you can easily use to diagnose a particular disease. So we work with a resident institution back then. It's called the African Center of Excellence for Genomics of Infectious Diseases. Dr. Happy, Professor Happy at Redeemers University, and they got like an $80 million grant from the World Bank to establish a fine institution. And they're doing great now. I mean, so most of the infectious disease projects I work on, I actually used to work with them at that institution. They have all the equipment, the sequencers. I mean, the sequencers that even some universities don't have in the US, they have it at that Redeemers University's Institute, and we did some couple of studies, but the thing is we do find at the level of validating those technologies, but when it gets to the stage of we actually introducing it to the government, that's when the wahala starts. So because it never gets to see the light of the day. I mean, we even got to a stage where we tried to work with the Federal Ministry of Health. I mean, the guy that was back then, they put a proposal inside the national budget. They got money for it, but the new guy just used it for something else. Not that they embezzled it, but they converted to some other project, which was not originally what we went for. So at the point we now wrote down proposal ourselves, we didn't work with them. We got funding directly from the African Development Bank. From one publication I made, they found me and contacted me. Oh, we can support your research. So we submitted a proposal. I think they gave us $150,000 just to do some public health studies on bats. We could try to find some therapeutic genetic materials that could help silence the expression of Ebola and some other infectious genes and things like that. But then we did some studies, but then there's still some follow-up studies that still needs to be done. I mean, of course, if $150,000 is not sufficient for such robust exercises or experiments or studies, so I mean that gets us in the way to get the conversation started. We're also able to work on COVID. We tried to design the COVID diagnostic test for Nigeria. We worked with NCDC. They tested some of the testing kits we tried to develop back then. But then when it got to the stage of implementation, we were working with the WHO back then too. I mean, up until the stage, they were going to do, I think, NYSC during that COVID pandemic that we should roll out that testing kit as an alternative to PCR kits that they were using back then, or those rapid kits, just to see how they compare. But then it never just got to see the light of the day. But at
Wow.
least some of those efforts are rewarded. At least we try to feel good by the fact that at least we're trying to do something for our country. Although we might not get the voice or we might not get the final right support we need, but at least we are doing our best. Maybe sometime in the future, they recognize our past records and say, okay, maybe you guys can do this for us this time around. But we'll just keep pushing, you know. But at least it makes us happy that at least we are doing our best. You know, we are trying the best possible we can for our country, not just a country, for Africa as well, you know. And if the United States recognize it, you know, but that's part of what they considered when I was going to apply for my ASIN visa, my EB1 thing. Those are the things they recommend. Oh wow, for you to have done this kind of, you know, research in Nigeria, it was beneficial to the United States as well. And they approved it, even though it wasn't even like something we read out. We showed them all the publications that, oh, they said that it's a good, you know, attempt, but it's not something that they will adopt. They said that's good enough for us. You did something by American standards, you know. So they still accepted it and said, wow, that's out of you guys, you're doing great. And we think you also, you know, um, do good for the United States, so which is why we are still here today. So I'm not saying that the Nigerian government does not, you know, appreciate. Some people appreciate those kind of efforts that you put in. I mean, maybe the right leadership that would ultimately, you know, follow through those things. I mean, they might have good intention. Maybe there's a lot of, you know, um, there's a lot of hoops to
Mhm.
fly over. You have to go through
Yeah,
one director, one minister, one, you know, before you
yeah,
eventually get to do something that is needed. So, but we just keep pushing and doing the best possible we can.
yeah.
So, yeah, that's it.
Hopefully, second to the last question. So, based on all this, you heard
Alright.
you know all this, and somebody saw this video. The president of Nigeria gives you a call
Mm-hmm.
and asks for your recommendations, and the president of America gives you a call, asks for your recommendation. What would you tell them?
In what? Which
In
aspect
in what?
exactly?
In science, in the current science in Nigeria, in current science in America, based on your
Well,
knowledge and expertise.
yeah. I mean, I just think, I mean, what every good government should keep doing is funding science, scientific research, basically. I mean, you cannot thrive if you don't support, you know, ongoing finding of knowledge. For instance, I'm trying to work on a technology right now that is supposed to help me um, help a particular protocol we use for our genetic testing, reproductive genetic testing, to make it smoother. All right. I'm trying to design a device that will help me do biopsy, embryo biopsy quickly and easily, because there's a step that's very strenuous and very, you know, complicated, that we have to find that very delicate piece and achieve it. So I talked with my professor, that's Dr. Asda, that I drew my design, showed him, can you build me this device? I want to test it and use it to at least, maybe not on human samples, maybe mice samples, and see if I can, you know, reinvent the process of biopsy, embryo biopsy, and make it more efficient. We're working on that. We don't have any money to run it. Maybe down the line we'll probably write it down and get some funding, or maybe find investors to help us. But then such processes, right, that builds or yields a new technology or a new efficient process, they don't get to see the light of the day without you having to put in some, you know, effort, resources, and funding as well. All right, just so that, you know, the scientist can birth his idea or his invention down the line. I know some governments try. I know we have NIH. You know, we have. I mean, in Nigeria, there is this, I think, TET fund that they give to university professors as well. So, but they can do more. That's what we're saying. They can do more to bolster, you know, good science, good inventions, and get them to the industry and market quite quick enough for the beneficial of the masses of the populace. So, earmark good funding resource to scientific research, because that's how every good nation would progress. Okay.
Yeah,
Yeah,
yeah, that's a
that's what I
safe
would have to
answer.
do.
You
Yeah,
gave a safe
safe.
answer. You kept yourself safe. That's good.
Yeah, yeah. You have to be safe in this time and era. Yeah.
So now, last question. I always like to ask a question that has nothing to do with the main topic. That's also relevant, and you can
Yeah.
imagine what that question is already. When
Okay.
did you start really get so much interested in singing and playing drums? When did you know that you have some musical genes inside you?
Well, yeah, that's a long time ago. I think as early as age 4 or 5, my mom used to tell me that I used to play the drums, and I play the drums for my church here. I'm going to play the drums at church tomorrow. I'm a roaster. So my mom said I used to gather all our pots from the kitchen and the plates, and I used to beat them. They used to call me Lulubomi call back in the days, and my mom would say, "Mark, don't take my pots and my pans and use them to play drums. Go to the church and tell the music director to teach you how to drum, or at least train you." So back in the days, as early as age 4 or 5, we used to be fascinated. We would sit by the drum set in church and watch all our big brothers, play the drums. Gradually, they started letting us play the drums too, and we're able to learn. So then we used to go through all these. Because I grew up a Baptist in Nigeria, right? So we have all these different groups in our Baptist setting. We have Sunbeam, that's age 0 to 10, whereby it's like a children church where they teach you so many things. You memorize memory Bible verses, like 40 Bible verses before you graduate. All right, so we have the choir group, we have a Christ Pet, we have Royal Ambassadors. For the ladies, they have Girls Auxiliary, the Lydia group. So those are, apart from the fact that those institutions or those organizations teach you Christian doctrines, how to live properly, they also exposed us to different life principles and teachings, all right, and how to also socialize, how to learn. A decent way of life, and they built my music life, right? I could say I'm a musician. I play the drums and I sing, and maybe not professionally, but at least in the church. I don't have a professional band that pays me every month or every year, but I think we've been invited to some programs where they give us honorarium. Honorarium is not like salary. At least they give us money and we share. We use it to buy Coke and Coca-Cola and other snacks. At least we say that we are working for God, and they also still appreciate our talents and our efforts as well. So, at a very young age, we were exposed to all those things by my local church, by my friends. I have a friend whom I used to boast that I taught him the sofa notes, and that guy plays the bass. He's a professional bassist. He now plays with Grammy Award winners, and
Mhm.
he does it professionally. That's part of how he actually is to make additional income himself. So yeah, at the very tender age, we're exposed to that, and we kept honing on that skill with friends, at our local churches and gatherings, and it's been quite interesting as well. So I'll keep playing the drums, maybe up until old age. It's one other thing I like to do as well. All
Yeah. I
right.
know the person you mentioned is, I think he's on Instagram, is hearing you. She's
Yeah,
hearing what you're saying.
George, my very
So,
good friend George.
yeah, yeah. Thank you for
Yeah.
joining. Waiting, we're watching, George.
Yeah.
So one of the, of course, when we were in SS1, I remember I used to beat the lockout for us then, and we dance to your
Yeah, I
skills.
did. Oh wow, I can't even
Yeah,
remember
yeah,
that.
of
Yeah.
course, I remember that so well. So thank you so much for
Yeah.
sharing that. Although, so one thing actually came to mind quickly now. I just want to hear your opinion about it. So most
Okay.
people that eventually become so famous in the world doing different types of music, they started from the church, just like you. The only difference is that you decided to stay in the church, and these other people are there already making different type
Mm,
of money. So,
making
what would,
millions, right?
yeah, what will your recommendation be around that? How can somebody pick their own path very well and stay on that path? And in the church too, how can people get really paid so that they don't have to go and do secular music?
Yeah, I'm going to be careful with that because I don't want to be the discussion of another social media virus, social
Well,
media talk. There's something going on about that on social media now. That one pastor showed the invoice of one music minister that wanted to be paid $10,000 for their administration, right?
mm,
Well, me, I'm not against being paid. I mean, for your craft, your trade. I mean, some of us just remain in the church because maybe we like the church or just like to be in the church environment. I mean, I'm not a professional drummer, but I could say I'm good enough for the church. All right. But some people took their trade to an extra level. Some people went to school to study music. All right. Music is their trade, is their craft, is their creative heart. So you don't, I mean, they might not be built to stay in the church, all right? And maybe the kind of music they learned. I mean, in the school, they introduced you to so many, genres of music, secular music, jazz, funk, all those different groups. I mean, the music that is recommended according to the Bible in church is hymns and, praise and worship. That's what the church, recommends us to do. But then, how about those secular musicians, the ashars, right? That does soul and jazz and folklore, and those new age guys that do Afro hip hop, the Davido and the Whiskey, they just do mashup, they have their own audience,
mhm.
and they are doing their shows and making it. I mean, I wouldn't invite the Wizkids to church to come and do special number for me, for instance, or an Olamide to come and do special number. I'd rather go for a Moses Bliss or Sinach or even the ones that are a little bit contemporary, Bidemi Olaoba, Testimony Jaga. I listened to that guy recently, very powerful talk too. So everybody has their own unique calling. Okay, you might be called to the church. Some people might be called to the masses. Some people, what they just want to do is entertain. They really are not interested in edifying you, which is what the church or gospel music is for. They are entertainers by profession. Just like you have people who do poetry, who do, painting, right? So everybody has his own craft, right? For those who are called to be gospel musicians, if you have the grace of not being paid for your craft or that you want to do it for free, by all means you can do that. There are some ministers who do that. I lived with my uncle who is a Baptist evangelist. Right, almost every week he gets called to come and preach in a church, and it's not within a locality, all across Nigeria. And some travels I used to go with him. I'm the one in charge of money. At the end of the week, they give us money. The church will raise an offering for us. They call it honorarium. And sometimes we take money in Aposhaka bags. Oh, I really want to count the money that, oh, this church gave us so money. And that is the money he uses. He doesn't have any other job. That's his job. He doesn't even have a church. I mean, he's like an itinerant evangelist. So for such a person, you invite him to come and preach in your church and you're telling him that he's doing God's work. How is he going to feed his family? For instance, of course, God will provide, but it is expedient or expected of you to also bless such individuals. They might not put a mark of, okay, this is how much I want, but they expect you that you also bless them. Because that's the money we used to run their house. When we take money from those revivals that my uncle used to go for, that's the money we used to buy food in the house. That's the money we used to take to school. That's the money we used to, even give to others as well. So that is their own calling. So it's a controversial subject. There are some people, all right, who will put a mark or a premium on their gifting that this is how much I think I'm worth. But when you tend to start doing that, I mean, it's a gray area. I also don't like to go into. But if you think that is what your gift is worth, by all means, go for it. If I am a public speaker right now, I'm not doing a preaching engagement to a church or a spiritual gathering. right? I would charge. I would put a bill. I would write you an invoice. Now, this is how much my talking engagement is going to be, you know? So some people do it professionally. And we also have to understand not everybody is called, right, to be a gospel musician or to be a gospel artist. And if you're chosen that lane, you have to understand that whatever it is they give you as an honorarium is what you probably just take. And some people think that they have a big brand now that it's not sufficient for you to give them even 100 or 200,000 naira or maybe even dollars as honorarium because they have to power. Maybe they have private jets that they have to transport their band. I mean, there was one popular preacher that was invited to Nigeria many years ago. I attended one of his programs, and I know for him to he transport himself with his own private jet. For him to transport his private jet, the fuel money alone, I know that church cannot afford it. you know, but he chose to come. They might not give him as much as is expected, but he knows that at least maybe they would appreciate his coming. All right, then maybe he knows that he's doing that kind of engagement for God. Maybe some other big church or big organization will invite him that will pay him the amount that is required for him to fund his operation. So some of them it's really about them being able to fund their operation, all right, to fund their craft and their trade. Right? They really have to buy equipment. They have to, you know, also earn some income if that is what they're doing professionally. So I really don't. I mean, I don't discourage those people. I don't even um, talk down at them if they choose to do that. So, I mean, everyone to his own. You do whatever you think works for you according to how comfortable you are in your spirit about it. All right.
Wow, wow. Thank you. Last question now, I promise. What do you want to say to our viewers? What do you want to say? What last thoughts do you want to share with our viewers?
All right. I mean, although I'm not, I mean, I don't really have anything. Just find a purpose, go for it. I mean, I used to have a purpose mantra that, in fact, there's a purpose formula. Maybe I'll write a book about it in the future. That there is a vision for a mission that is usually powered by God, and in time, it's going to happen. And sometimes you might need a helpmate for that. So I
Hmm.
had a formula for purpose, which has the variables as mission and vision and God and time and help. Right? And sometimes you have to have a driving force for your life, which is your life mission. And that you have to have a vision that is wrapped around your mission. And sometimes or always, God is the constant in it, and every vision has is time bound. Like I like to reference the scripture that says, "Write the vision, make it plain, and in its due time, it's going to happen." So there's a time component for every vision, and almost always you always need a help. All right, the help could be your helpmate, it could be your wife, it could be a business partner. It could be someone who just takes an interest in what you're doing. So figure out all those variables and you would eventually lead a fulfilling, purposeful life. I'm still trying to, figure out mine too, and I know that everybody is still trying to figure out. But if we can define all those variables about our mission, our vision, I recognize there's a God factor, it's time bound, and there's always an help required, then you'll be fulfilled in your place of purpose and calling. Thank you.
Good. Thank you so much. Thank you. I took all the time today. We had time to
Thank you.
discuss. Thank you so much. I double time, literally double the time I have for my podcast with
Thank you.
Spence.
That's
That's
fine.
just we've been friends for almost 30 years. 30.
Yeah, yeah, I agree.
Yeah. Good, good. Thank you so much. I really appreciate it. I'm not taking
All
this for
right.
granted. I really
Yeah.
appreciate your time, your
Thank you for
energy.
having me.